Hello, and thank you for joining today's NCCN patient webinar on uterine cancer. My name is Erin Vidic, and I'm a writer for the NCCN Patient Information Team. NCCN stands for National Comprehensive Cancer Network. NCCN is a not-for-profit alliance of 33 leading cancer centers across the United States devoted to patient care, research, and education. NCCN Foundation is a not-for-profit organization that raises funds for NCCN patient resources, including patient guidelines and webinars. These are funded using financial support from generous donors. The NCCN guidelines for patients are based on the NCCN clinical practice guidelines used by healthcare providers worldwide. They explain the same options for cancer care, but are written for patients and their caregivers, family, and friends. You can view and download free copies of the NCCN guidelines for patients from the NCCN website. High-quality printed copies can be purchased through Amazon. If you ordered a free book when you registered for this webinar and have not yet received it, it should be arriving shortly. The NCCN webinars for patients complement the NCCN guidelines for patients. They cover a series of topics discussed by expert presenters. Viewers have an opportunity to ask questions at the end of the presentation. This brings us to the presenters for today's webinar. I'm very pleased to introduce Dr. Emma Barber. Dr. Barber is an assistant professor of gynecologic oncology and director of robotic surgery at the Robert H. Lurie Comprehensive Cancer Center of Northwestern University. Following Dr. Barber, we will hear from Karen Novak, an acute care nurse practitioner in oncology. Ms. Novak also joins us from the Robert H. Lurie Comprehensive Cancer Center at Northwestern. Our third presenter today is Emily Wise. Emily is a cancer survivor and the patient advocate on the NCCN Cervical and Uterine Cancers panel. Now I will turn it over to Dr. Barber.
Thank you so much. Thanks so much for having me. I'm really excited to be here today. I'm going to be talking about endometrial cancer and uterine sarcoma, focusing on treatment. So learning objectives for my talk, we're going to go over the epidemiology of uterine cancer. We're going to talk about the differences between endometrial cancer and sarcoma. We're going to review the histology and grading of cancer, the staging of these cancers, and then the treatment, both surgical and medical. And within medical, I'm going to highlight both chemotherapy and immunotherapy. So first of all, the epidemiology of uterine cancer. There's around a 3% lifetime risk of developing uterine cancer for women. And as you can see here on the right, uterine cancer was actually the fourth most common cancer in women in the United States in 2021. So it's a relatively prevalent cancer. The majority of cases of uterine cancer are sporadic. And what that means is they just kind of happen, due to bad luck or other risk factors. They're not really genetic. And the average age of diagnosis is 60 years old. There are certain risk factors for uterine cancer. Most sort of center around excess estrogen. So things like longer time between somebody's menstrual periods, or, having more like peripheral fat tissues that can make estrogen. This can be associated with the development of uterine cancer. Although the majority of cases are sporadic, there are important genetic risk factors for some people that have uterine cancer, and specifically a syndrome called Lynch syndrome can increase the risk of uterine cancer. So within uterine cancer, there's two large types of cancer. There's endometrial cancers and uterine sarcomas. And I'm just going to talk a little bit about the differences of these. So endometrial cancer is really cancer that starts here in the lining of the uterus. So sort of like the carpet or the inner layer of the uterus. Endometrial cancer is far and away the most common type of uterine cancer. And it's something that, people tend to present with some vaginal bleeding or discharge, and they can undergo a biopsy. So there are, to diagnose the cancer. So there are diagnostic tests available for endometrial cancer. In contrast, sarcoma is actually a cancer of the muscle wall of the uterus. So you can see here, it's kind of growing in the muscle wall. It's not in that inner layer, and it's pretty rare. It's only around 2 to 5% of all uterine cancer. Sarcoma is also a really tricky cancer because there is no diagnostic test, to really find it. It mimics fibroids, which are really common. 50 to 80% of women have them. And so on different imaging, ultrasounds, or different things, fibroids and sarcoma can kind of be mistaken for each other. And so there's no real diagnostic test to diagnose a sarcoma, kind of before surgery. And those are some of the main differences between the two cancers. For any cancer, there's always the issue of histology and grade. And so I wanted to go over a little bit about what these things mean. First, I'm going to go over the grade of the cancer. This often gets confused with the stage of the cancer, but grade is really how aggressive are these cells? How do they look under the microscope in terms of their ability to sort of metastasize and grow quickly. And so cancers are graded 1, 2, and 3, with 1 being sort of like the least aggressive type of cancer and 3 the most aggressive. And the grade also relates to how much it looks like the place that it started from. So this picture here is an example of like a grade 1 cancer. It looks pretty similar to how the endometrium would look under a microscope slide. You can see these sort of glands, and that would be kind of how normal lining of the uterus looks. This is grade 2, and then this one is grade 3. You can see by the time you get to grade 3, this cancer has really changed and become so different from the place that it started. And so grade is a really important thing when we think about the type of cancer somebody has. Additionally, there's histology. Histology is also how the cells look under the microscope. It's almost like the flavor or type of cancer. And in endometrial cancer, specifically, there are sort of 2 types of histologies or cancer. So type 1 cancers tend to be endometrioid cancers. These are cancers that mostly are low grade. They're often caught early before they've spread. And they look more like the endometrium, sort of under the microscope. Type 2 cancers are non-endometrioid cancers, so it would be like serous, clear cell, carcinosarcoma. These cancers are rarer, and they're usually more high grade. They spread really quickly, so patients may often be at a higher stage when they're diagnosed. And so these are kind of 2 different types of cancer that endometrial cancer is often described as. So this is something that's been new for us in the last, 3 to 5 years in endometrial cancer. We used to always classify these cancers based on how they look under the microscope, the grade, the histology, the things we've just talked about. But what we were kind of seeing is we may have patients that have endometrioid cancer that's grade 3, but the cancers are behaving so differently from each other. And so we sort of thought, some are really aggressive, some are less aggressive. And we kind of were thinking there's more to this story than just how these things are looking under the microscope. And that got into molecular classification. And molecular classification is really looking at the genetics of the cancer. And it's been shown that when we look at the genetics of the cancer, we can divide endometrial cancer into 4 different categories that are here in the blue, based on the actual kind of genetics of the cancer. So it's now recommended that all endometrial cancer is molecularly classified, and this is from the NCCN guidelines. So the first thing that we can do is we look at POLE sequencing, which is testing for the POLE gene. If the patient has POLE, then that cancer is POLE mutated. If they don't, then we do further testing. We test for mismatch repair protein immunohistochemistry. And if those proteins are missing, then the patient is MSI high, or you may also see DMMR, missing mismatch repair proteins. If the expression is retained, then we do another test. We do P53 immunohistochemistry. If it is abnormal, then they're called copy number high or P53 mutated. And if it's normal, then that's kind of everybody else. It's copy number low or no specific molecular profile, NSMP. And really a seminal paper that looked at this categorized the cancers not by histology, not by stage, just by their molecular subtype. And you can see that here in this Kaplan-Meier curve. And so every time this line gets a little bit lower, that is a sign that someone in that group, their cancer has recurred. So you'd really like to be a flat line up here. And what this showed is that the molecular subtype is strongly correlated with prognosis. So patients who are blue on this blue line, they are poorly mutated. They are doing really well, kind of no matter what. Whereas patients that have P53 mutations, they're in the red, their cancer is really coming back at a much faster rate. So this showed us that beyond just histology, we can really molecularly classify cancers. That's helping us figure out not only prognosis, but how we take care of people. A little bit more detail about these molecular classifications. What does it mean if I'm in these different groups apart from prognosis? So poly-ultramutated is relatively rare. It's around 2 to 7% of all endometrioid cancers. And patients that have poly-ultramutated tumors have a very favorable prognosis, sort of independent of what treatment they have. So a lot of studies are looking at maybe doing less treatment for these patients. Patients that are MSI high or dMMR, these also have a very high mutation rate. And this is really a very strong biomarker for response to immunotherapy. So it's very important for us to know that so we can use immunotherapy. Patients that are copy number high or P53 mutated, these are really aggressive tumors. Most serous cancers are P53 mutated, so it's kind of a serous-like tumor. And again, these cancers tend to have very high recurrence rates. Chemotherapy may be a little bit more effective for these P53 mutated tumors. The last group is copy number low, or that NSMP, no specific molecular profile. That is basically everybody else. So it's a really heterogeneous group with lots of different things going on. And a lot of research right now is trying to dig into this group and further separate it so we can figure out how to take better care of these patients. We have talked a little bit about the importance of molecular profiling, but I also want to link it to genetic testing, or actually testing the genetics of the patient themselves, not just the tumor. So it is recommended that every single endometrial cancer specimen, hysterectomy, biopsy, have testing for mismatch repair proteins. So there are 4 proteins that I've listed right here, and these 4 proteins can be tested in everyone's endometrial cancer. If these proteins are missing, it means that there is an inability of either the tumor or the patient to repair DNA. And so if these proteins are missing, it's important that we take an extra step and do more testing. First, we do something called hypermethylation testing. That is a sign that maybe it's only mutated in the tumor and these proteins are only missing in the tumor. But if that hypermethylation testing is negative, it is possible that the reason we're seeing these mismatch repair proteins not present in the tumor is that they're also missing in the patient's blood. So if that is the case, it's very important for the patient to have blood genetic testing to basically look for something called Lynch syndrome. Okay, this can be a sign of Lynch syndrome. Lynch syndrome is a genetic defect in the body's ability to repair DNA that makes it vulnerable to a whole host of other cancers. It has listed here all the different cancers, including uterine cancer, but other cancers that patients with Lynch syndrome are at risk for. So it's important for us to find those patients and make sure that they're aware of these risks. And then it's also important for family members to know about that. So that's an important genetic testing piece in uterine cancer. We talked about grade, stage, histology, molecular profiling, and also wanted to highlight the staging of endometrial cancer. So endometrial cancer is staged surgically, and staging in endometrial cancer has actually undergone a really big change in the last year. So I used to always say that staging is really about where the cancer is, where the cancer isn't. It's about the location of the cancer, whether it's spread from the place of where it started. And that's traditionally how we would think about staging, really location of cancer. But now in endometrial cancer, we are actually incorporating all kinds of things beyond just the location of the cancer into the stage. So the histology of the cancer, like a serous cancer or endometrioid cancer, that's now incorporated into the stage. And also the molecular subtype is incorporated into the stage. And the reason for this is that these things are strongly associated with prognosis, and they're also strongly associated with the right treatment options. So staging really lets us know what's going on with this cancer and what's the next best treatment. And histology and molecular subtype, in addition to the location of the cancer, are now felt to be really important for that in endometrial cancer. Surgery is really important for the treatment of endometrial cancer, and it's the correct treatment for everybody that doesn't have, sort of metastatic disease or spread. Most endometrial cancer surgery is done minimally invasively. There have been multiple randomized control trials confirming that this is, kind of the treatment of choice. So it can be done with either robotic surgery or laparoscopic surgery. Minimally invasive surgery just means little incisions instead of a big old-fashioned incision. For most patients, the ovaries are removed during surgery. Not everyone, but more commonly that's the case. And now really sentinel lymph node mapping has emerged as kind of the standard of care for endometrial cancer. So you can see here, if you had a cancer inside the uterus, here represented by that blue, the cancer could spread through lymphatic pathways, right, to spread kind of through the body. And during this surgery, we want to figure out if that happened so we can take better care of people. The old-fashioned way that we used to do things was to remove all the lymph nodes here. And we just want to get them all and make sure that there hasn't been spread to the lymph nodes. This worked fine for finding cancer, but it had some side effects, namely lymphedema or swelling of the legs that happened in around 50% of patients. So a new technique was developed called sentinel lymph node. That takes advantage of the fact that we can actually inject dye into the cervix, and that dye will travel the very same path that a cancer cell would travel to reach this first lymph node here represented by the green. That first lymph node in the pathway is called the sentinel lymph node pathway, sentinel lymph node. So we just take out that one lymph node instead of all the lymph nodes. If there's cancer in any of the lymph nodes, 97% of the time, it's in that very first sentinel lymph node. And so this way we can be a little bit more precise with our surgery. Surgery for uterine sarcoma is a little bit different. In uterine sarcoma, we do mostly open surgery. So we make an old-fashioned incision instead of doing it through little incisions. This is because a lot of sarcomas can be quite large and we want to remove them intact. We don't want to be cutting them up or risking them spreading. If there is any surgery done, for something that's thought to be a fibroid, and there is a plan to sort of cut it up as shown here, it's very important to be done within a bag or a contained specimen removal. For most uterine sarcomas, removal of the ovaries is also recommended. After we do surgery, that will tell us what the stage is of the patient and if there's any adjuvant treatment that's recommended. Adjuvant treatment means that, we have no evidence of cancer in a patient, but we want to give treatment to try to decrease the chances that the cancer would come back. Radiation treatment is part of that in endometrial cancer. So I do want to say radiation therapy is normally not used for uterine sarcoma, except for rare circumstances, but it's quite commonly used for endometrial cancer. And radiation treatment can consist of whole pelvic radiation, meaning radiation delivered to the whole pelvis, normally for patients that have like cervical invasion or extensive LVSI or other high risk factors for local recurrence. Vaginal brachytherapy, that's kind of depicted over here. This is radiation given locally in the vagina, and we tend to do this for high intermediate risk endometrial cancer. Systemic treatment or treatment that's delivered through an IV through the veins is also really important in our treatment of all uterine cancers. So we can think of systemic treatment as either adjuvant therapy, like I talked about, or treatment for active metastatic disease if we actually see a tumor on a CAT scan or something like that. Adjuvant therapy has not been shown to be effective for sarcoma, but it is something that we use in endometrial cancer. And systemic therapy could include chemotherapy, immunotherapy, or targeted therapies. And I'll go over a little bit about what those are. So first, this is an example of chemotherapy and how chemotherapy works. Chemotherapy takes advantage of the fact that cancer cells grow faster than regular cells. So they're dividing a lot more. And basically, the chemotherapy goes into the cells that are dividing and kills them. So it kind of preferentially is going to kill the cancer because it's dividing more, but it can also kill regular cells that are dividing, and that is responsible for a lot of its side effects. Immunotherapy works a little bit differently. It actually will activate your body's immune system to fight against the cancer. And targeted therapies are specific drugs that are targeted towards proteins that are present on the cancer, and it's sort of targeted to kill those cancer cells. Chemotherapy for endometrial cancer, we tend to use two drugs, carboplatin and paclitaxel, at the doses that are listed there. The reason for that is that there's a seminal study, GOG 209, that really established these as the standard of care. And they have some side effects that I know some of my colleagues are going to go over a little, but that I've listed here. We also can use chemotherapy for uterine sarcoma, mostly for disease that's unresectable. We can't do surgery on it, or metastatic has already spread somewhere. The drugs we tend to use for this are doxorubicin, gemcitabine docetaxel, doxorubicin with trabectedin, followed by trabectedin maintenance. Immunotherapy, this is a really hot topic and important piece of treating endometrial cancer. So again, the mechanism of action is different. It's activating the immune system to attack the cancer. And so the side effects that come from it are a little bit different than chemotherapy. It's basically that your immune system can actually attack other parts of your body. It's sort of a over revved up immune system that attacks the patient's body. So the side effects most commonly are things like rashes or issues with the thyroid. Those are organs that tend to be more commonly attacked by the immune system, but it can also really attack sort of anywhere in the body, the lungs, the colon, the pancreas, different areas. But those side effects are relatively rare. The most common type of immunotherapy is something called a checkpoint inhibitor, and I've listed some different names down here. I wanted to highlight this because this has been a super, super cool advance in the last year in endometrial cancer. We now have, for frontline treatment of patients with stage 3 and 4 endometrial cancer, the use of chemotherapy in combination with immunotherapy. So these are two very exciting studies that were published earlier this year in the New England Journal of Medicine, both looking at checkpoint inhibitor plus chemotherapy compared to placebo plus chemotherapy in patients with endometrial cancer. And you can see here, these are the Kaplan-Meier curves, especially for patients that have mismatch repair deficiencies. So that biomarker-driven treatment that we talked about with molecular classification. At 12 months, patients that got the checkpoint inhibitor in addition to chemo, 74% of them had not had the cancer come back, compared to 38% that had chemotherapy alone. So really showing the benefit of this drug, sort of across everybody, but specifically for patients that have mismatch repair deficiency. We also use immunotherapy in the second line. This is just another example of, after patients have received chemotherapy, we used to try a different chemotherapy. This study tried pembrolizumab, again, a checkpoint inhibitor, plus lenvatinib, a drug that works against new blood vessel growth. And you can see here that this was much more effective than the old chemotherapy that we used to give. So really showing how immunotherapy is helping us take better care of endometrial cancer patients. I wanted to end just by talking about clinical trials. The reason we have all these drugs and everything we've been talking about, even surgical techniques, comes from testing them in clinical trials. So clinical trials are always a good thing and a good option to think about when you're undergoing cancer treatment. I wanted to highlight that we tend to think of clinical trials as being, drugs, different chemo or immunotherapy, but they're actually available for all times in cancer care. So you can be part of a trial before you have surgery. You could be part of a trial during surgery, like a sentinel lymph node. That used to be something that was in clinical trials. Adjuvant treatment for metastatic disease. And then there's also trials of supportive care things like, trying to prevent neuropathy or other, nausea or other side effects that can come from chemotherapy. And I think NCCN has some really good resources on this, so I included the link for that. So thank you very much for your attention, and I want to turn it over to my colleague, Karen Novak, to go over some more details about endometrial cancer.
Hi, thank you for inviting me to speak here. It's very exciting. I'm an old oncology nurse, so I'm very tickled to talk to you about chemotherapy side effects and management strategies for both endometrial cancer and uterine sarcomas. As Dr. Barber had stated, before you find out that you need some form of systemic chemotherapy, plus or minus immunotherapy or a monoclonal antibody, plus or minus radiation therapy, you need to have some form of surgery along with the histopathologic evaluation of that tumor and molecular testing. Once it's decided that you do indeed need some form of chemotherapy, you will receive paclitaxel carboplatin chemotherapy, plus or minus pembrolizumab, plus or minus trastuzumab, or plus or minus dostarlimab. A typical day that you should expect when you get your chemotherapy starts in the labs. You'll get your labs performed, and then you'll come see your MD or your APP. And here's where you talk about your side effects, things that are going well for your treatment, things that aren't going well, and things we need to improve upon for you. Then you'll be released to the chemotherapy infusion area, and your chemo nurse checks you in and gives you your medications. Chemo nurses are a wealth of knowledge. If you forgot to ask your doctor something, those chemo nurses are usually really proficient and knowledgeable. Ask your chemo nurse as well about side effects. After your chemotherapy, if you're stable, they'll take out your IV, and then they'll give you your discharge instructions. So they'll go over your medications on how to take them after chemotherapy, any new medications we talked about based on side effects, and the plan of care for your next treatment. If you needed radiation therapy at this time, then you'll be released to go on to radiation oncology. I'm going to talk about the main side effects for all of the drugs that we use to treat endometrial and uterine sarcomas. Because of time, I can't repeat them or double up on them, but I will try and hit the main ones for each drug. Paclitaxel or Taxol causes stocking glove peripheral neuropathy. These are the biggest things that patients report to us. Numbness and tingling in the fingers and the toes. If this happens, be honest with us, because this is a dose-limiting toxicity. This can be something that lingers with you the rest of your life. If you start to have this, we'll recommend some over-the-counter supplements, such as vitamin B12, 1,000 micrograms a day, alpha-lipoic acid, 600 milligrams a day, magnesium glycinate, 500 milligrams a day, L-glutamine, 1 gram powder, 1 to 3 times a day. If you have pain associated with your neuropathy, then we're going to recommend gabapentin, and we can start with a low dose and ramp that up to control the discomfort. Capsaicin is a cream that's over the counter. You can put a thin layer on your fingers and toes, and it releases substance P, which is supposed to provide you comfort from the numbing sensation. And as always, massage and acupuncture to your hands and feet will help increase circulation and improve those symptoms. Hair loss and alopecia. Most traditional chemotherapies cause either hair loss or hair thinning. You can use a cold cap therapy during your infusions. It is labor intensive because you have to do it during the infusion, plus you have to do it for several hours after your infusion is complete and at home. If you opt not to do that, that is fine as well, because your hair grows back relatively quickly once you're done with your chemotherapy. And there are some nice medications now that promote hair growth. You can also get medications called, well, there are serums over the counter, Rapid Lash and Latisse, that help your eyebrows and eyelashes grow back. Nausea, vomiting, constipation, and diarrhea. Most chemotherapies have nausea and vomiting in their profile, some immunotherapies as well, but we give you medications before and after that will help prevent this. We're pretty good at covering this now. But when you take something for nausea and vomiting, you're going to get constipated. You need to take not only a stool softener, but a stool stimulant to help move your bowels. Colace is a stool softener. Miralax and Senecot are examples of stool stimulants. Diarrhea is really rare with chemotherapy at this point, but if you start to have loose stools, you can take a half a tablet of Imodium to start with to see if it combats the problem. Carboplatin causes delayed nausea and vomiting. So that means 3 to 4 days after your chemotherapy is done, you might have nausea and vomiting. You want to take your medications as prescribed after chemotherapy. Don't be cavalier and miss them, because it's very hard to play catch up once you start to get sick from your carboplatin. Another thing patients talk about are taste changes from the carboplatin, because it's a metallic-based compound. So you want to eat off plastic utensils, eat room temperature foods, nothing too hot or too cold, nothing too spicy, and use some fresh citrus fruit in your water to help combat the taste of the metal. Pembrolizumab or Keytruda is our immunotherapy we use with endometrial cancer. It has a unique set of side effects. One includes a rash. The rash can be as simple as just a red mark on your forearm, well controlled with over-the-counter hydrocortisone cream. Or it could be over 40% of your body, where we have to send you to Oncoderm for possible skin biopsies and call in high-dose steroid creams for you to use. Sometimes the rash is bad enough We will hold your pembrolizumab for a week and hopefully not have to start you on any oral steroids. You can get pneumonitis on pembrolizumab. So if you suddenly develop shortness of breath and a dry cough, let us know. We'll make you come in and either do a chest x-ray or a chest CT to look for inflammation on that imaging. And if you do, then we have to hold the therapy and start you on inhalers probably and oral steroids and refer you to pulmonary. Diarrhea and colitis. This isn't just one episode of diarrhea a day. This is people who have 8 to 10 bloody stools a day and cramps. If this happens to you, you got to be honest, let us know. We'll bring you in for a CAT scan of your abdomen and pelvis and look for inflammatory processes. And if that is happening, then we'll hold the therapy, start you on oral steroids, and send you to GI for an evaluation. Immunotherapy and some monoclonal antibody therapies can cause these immune-mediated endocrinopathies. So adrenal insufficiency, thyroid failure, and type 1 diabetes is in this side effect profile. If you suddenly have severe fatigue, muscle weakness, hypotension, dizziness, let us know. We should draw some cortisol levels on you and other adrenal studies to make sure you're functioning fine. If you're not functioning adrenally appropriately, then we have to hold your therapy and start you on some oral steroids. We expect your thyroid to fail at some point on immunotherapies. We just replace it with Synthroid. We don't know, well, most of the time your thyroid doesn't wake up back to normal even after therapy is complete. So unfortunately, you may be on Synthroid the rest of your life. Some patients, it's very rare, have developed type 1 diabetes. We use these medications as maintenance parts of therapy. So you're on them for a prolonged period of time. If you start to have excessive thirst, weight loss, lots of urination at night, do let us know. We should test your hemoglobin A1C and make sure you don't have elevated sugar levels. We could start you on an oral anti-hyperglycemic and even injectable insulin if necessary. Trastuzumab or Herceptin can cause cardiac toxicity. We're going to get an echocardiogram, which is an ultrasound of your heart, and we specifically look at the left ventricular function of your heart. We get it at the first treatment and at the third treatment and do this throughout. If your left ventricular ejection fraction starts to fall, then we have to consider stopping the trastuzumab or putting it on hold. You can also get some significant pulmonary toxicities similar to pneumonitis. So if you start to have a dry cough, let us know so we can act quickly for you. Dostarlimab or Jemperli has the same side effect profile as pembrolizumab and trastuzumab, except it can also offer you uveitis, which is inflammation of your eyes and irritation of your eyes. And that means you need to see the ophthalmologist and likely take lubricating and steroid eye drops throughout the day. Per the NCCN guidelines, I've listed some medications we use systemically for recurrent endometrial cancer, but won't go through all those side effects. And first-line therapies for the treatment of uterine sarcoma. As you can see, doxorubicin is probably the mainline treatment that we have for this disease process. You can pair doxorubicin with trabectedin, ifosfamide, or dacarbazine. And you can also treat the patient with docetaxel gemcitabine. The doxorubicin and docetaxel gemcitabine are our preferred first two treatments to start. Doxorubicin is an older drug, been used many years for breast cancer and other cancers. It causes cardiac toxicity, so similar to trastuzumab or Herceptin, we're going to get that echocardiogram prior to starting, and then every three cycles. There's a dose limit that you can receive of adriamycin, so we know we probably can't go past 8 cycles of using adriamycin. You can have nail bed changes and skin changes with adriamycin. You can get dark ridges in your nails. That takes time to grow out and get better. And you can also look like you have an overall generalized tan. If you've had any radiation previously for another cancer anywhere on your body, when you receive adriamycin, that area will become a little bit red, like a sunburn, and slightly irritated. Docetaxel or Taxotere is hard on your bone marrow. It causes a little more neutropenia, lowered white count, red count, and platelets. You can also have significant fluid retention. We give you steroids before and after the infusion to try and combat this, and prefer not to use any diuretics because it's dehydrating and hard on your kidneys. So we ask that, yes, you gain a little fluid, but hang on. Once you're done with the treatment, you'll get rid of all that water weight. It too can cause some skin changes and nail bed changes, such as the ridging on your nails. And wherever you receive the docetaxel, if you do it through a peripheral IV, meaning they stick you in the hand or arm, you will have this darkening of that vein after the infusion. No matter how much we try and hydrate you afterwards, it just kind of stains the skin and the vein. Gemcitabine or Gemzar will give you flu-like symptoms the first 24 hours after you receive this drug. You can take Tylenol and Motrin, but if you develop a fever greater than 101.5, give the office a call to rule out any infection. And it can cause some pretty rare side effects with your lungs as well: pulmonary fibrosis, pneumonitis, pulmonary edema, acute respiratory distress syndrome. So if you start to have those, you got to let us know so we can do the appropriate workup. Trabectedin or Yondelis, it can cause rhabdomyolysis, which is breakdown of your muscles during the infusion. And the byproduct of this breakdown causes some renal function problems. So we monitor your labs pretty frequently, and we give you lots of IV hydration before and after, and expect you to drink lots of water before and after. You can also get an acute headache during the infusion, for which Tylenol and Motrin is accessible. Ifosfamide is an old drug used to treat sarcoma, and it has two significant toxicities. One of them is a nervous system toxicity. This generally happens in our elderly population who have poorer protein stores. If you receive this medication and you go home and you're not acting quite right with your family and they're noticing this, have them come back to the clinic. We need to give you an antidote infusion of methylene blue, and it fixes the problem. You can get bladder irritation or hemorrhagic cystitis, which is blood in the urine. It can be pretty significant and uncomfortable. So we're going to give you aggressive hydration before and after, and give you a medication called Mesna, which is sodium sulfonate, and it will help protect and coat your bladder so that you don't have these side effects. Dacarbazine, DTIC, it has traditional chemotherapy-related side effects, such as affecting the bone marrow, nausea, vomiting, flu-like symptoms. Radiation side effects. Radiation-related toxicity depends on where you receive your radiation, whether it be in your pelvis or the vagina. The toxicity can begin as soon as 2 weeks after the start of radiation therapy and last for months to years after you complete it. And we like to think that the toxicities usually peak 2 weeks after completion of your therapy. Some common radiation-related side effects are diarrhea, constipation, vaginal dryness, discharge, bleeding, and strictures of the vagina, blood in your urine, bladder pain, yeast infections, blood in the stool, crampy, diarrhea, vulvar pain and ulcerations, skin irritation and burning where you had the radiation, ovarian failure, infertility, diminished libido, painful intercourse, moderate to severe fatigue, weight loss, and electrolyte imbalances. If you have any kind of blood in your urine or bloody stools, keep track of how many you're having, tell us. This usually happens further on down the line away from the radiation therapy, and sometimes we have to send you for hyperbaric oxygen chamber therapy. It shows a real proven benefit. Plus, have you follow up with urology and gastroenterology. Constipation can cause hemorrhoids. Let us know. We can give you steroids, suppositories, because the hemorrhoids can be pretty bad after radiation. Vulvar pain and ulcerations. Hyperbaric oxygen chamber treatment can help with those if you develop them secondary to your radiation. Your vagina is important. We want it patent so that we can monitor you after you complete your therapy for recurrence. So vaginal estrogen can be used, vaginal hyaluronic acid tablets can be used, and use a vaginal dilator to maintain patency. Fatigue, the only thing that battles fatigue is activity itself and maintaining a good hemoglobin. So we can continue to monitor your labs afterwards to make sure that your hemoglobin is where it should be. This is just a toxicity management tip sheet because I know I'm going quickly, and you can review that. And then survivorship concerns. I think as a nurse, I've seen when the patient finishes their treatment, this is when the real work starts because they're not actively treating their cancer. This is when they report emotional distress, survivor guilt, difficulty in the long-term management of their toxicities, financial concerns they put to the side become a reality. And sometimes there's changes in interpersonal relationships and themselves that they need help with. Emily is here to she's a patient herself, and she can speak word of mouth on how to help us with these issues. Thank you.
Thank you, Karen. First of all, I want to thank NCCN for having me. It is an honor to be here with you all today. I want to start off by telling you a little bit about myself. I have been the patient advocate on the NCCN Cervical and Uterine Guidelines panel since 2016. We meet annually to review the guidelines and to ensure we are publishing the most recent and up-to-date information. My role as a patient advocate is to be the patient's voice when looking at screening, diagnosis and evaluation, treatment, assessment of response, surveillance, and finally survivorship. I also attend the NCCN patient advocacy meeting held annually in Washington, D.C. So what makes me qualified to be the patient advocate? Well, in 2004, I was diagnosed with cervical cancer. I was 30 years old, had a 4-year-old and a 1-year-old at home, and the last thing on my mind was cancer. The picture on the top right was taken just a few days before my diagnosis. I was experiencing some abnormal bleeding, but it had 4 pap smears over a course of a year, and everything appeared to be normal. A month after my 4th pap smear, I went in for my annual exam where my doctor did a 5th one, and it finally came back abnormal. The next step was a cone biopsy, and a couple days later, I found myself in an exam room set up with an extra chair for my husband and a box of Kleenex in between, where my doctor shared with us the news that she had found cancer. I honestly started to laugh because I was in such shock. How could this possibly be? I was young, healthy, and had never had any health issues until now. I went through chemotherapy, external radiation, brachytherapy, which is high-dose internal radiation, and finally surgery. All of these therapies combined allow me to be here with you today and allow me to proudly say that I have been cancer-free now for 18 years. My cancer journey may have ended there. However, I had significant long-term side effects. My radiation damage led to a bowel resection where they removed 2 feet of my bowels and a ureter reimplantation just a few years ago. To this day, I continue to struggle with malabsorption and chronic kidney infections as a result, but for the most part, I'm able to live a very normal and healthy life. You are likely here because you have been diagnosed with cancer and are looking for some guidance. We have learned that when most patients are diagnosed, they take the 5 F's into consideration when determining their care plan: fear, facts, faith, finances, and last but certainly not least, family, which is friends and family combined. Let's start off with fear. Fear can be all-encompassing when you are diagnosed. You have more questions than answered, and the unknown can be very scary. I want to remind you that first and foremost, you have a voice. You are in control, even though it feels as though everything is completely out of your control. It is okay to get a second opinion or even a third. I thought that getting another opinion would somehow hurt my doctor's feelings or make it awkward. However, he encouraged it. I needed to be comfortable with my care team, the diagnosis, and the treatment plan. Don't be afraid to ask questions for clarity. There is no such thing as a dumb question, and it is okay to ask the same question multiple times until you understand. Bring someone with you to the appointments, especially ones where care decisions will be made. Ask them to take notes for you, and if you don't have someone with you, record the conversation on your phone. I personally brought my dad with me to the appointments because both my husband and I were so overwhelmed, we would walk out of the room and completely forget what was discussed. It is important to share your communication style with your team. For instance, do you like and want to hear percentages? Do you prefer phone calls via my chart messages? This helps your team know how to best care for you and in the way that you are most comfortable with. And lastly, ask your care team if there's a previous patient that they could connect you with. Speaking with someone who has been in your shoes can be incredibly helpful. If they don't have a referral, there are some organizations such as Immerman Angels. They have a database of survivors that they can link you with to offer personalized connections and one-on-one peer support. They also offer the same for caregivers, which is extremely important because we all know that cancer doesn't just affect the patient, and in some ways it can be harder on caregivers because they feel helpless. Facts, faith, and finances. Looking for facts can be intimidating. It can also be difficult to trust that what you are reading is correct. To help you learn the facts, the NCCN has published guidelines for patients specific to uterine cancer. In this book, we cover everything from the basics about uterine cancer to survivorship. There is a glossary of terms which can be extremely helpful to refer to throughout your journey. We also include suggested questions to ask your care team, a list of symptoms to stay alert for, and when to contact your doctor. This book is available to download yourself, or you can request a paper copy. Faith is very personal and individualized, so I won't go into very much detail. Just know that there are resources available, such as a local church group, or most cancer centers do have a spiritual care team. The third F is finances, and the financial toxicity of cancer is honestly a topic that we could spend an entire webinar on, but be aware that there are people and resources available to assist you. Ask to speak with a social worker or possibly look for grant options on the internet. Just don't be afraid to ask for help. Nobody should have to make a choice between getting treatment or not based on finances. The final F is family. Family, again, friends and family, is so incredibly important during this time. You should not go through this alone. It is a time to build your support team, which could include your spouse, your friends, your family, a social worker, a patient navigator, a therapist, church group, or a cancer support group. Cancer is all-encompassing and doesn't just affect you physically. When looking for support, remember that it comes in many different forms. Emotional support may be someone to talk to, such as a therapist, someone to provide encouragement, or maybe someone to share a side effect with your care team because you may not have noticed it. Physical support may look like someone to care for you when you're not feeling well, a walking partner, a ride to a medical appointment, or dropping off a warm meal to you and your family. There's also financial support. Aside from monetary support, financial support may look like calling the insurance company for you on your behalf, organizing your bills, or engaging a social worker for assistance. And lastly, I want to talk about survivorship. When you are done with your treatments, it is natural to feel a lot of emotions. Sometimes all of the fear that you felt in the beginning resurfaces, but take a moment to acknowledge what your body has just gone through. Be patient with yourself, both physically and emotionally. Allow yourself the time to feel these emotions and the time to heal. Remember that just because you are done with your treatment doesn't mean that you are going to feel well the next day. The side effects can be short-term or long-term, all of which should be addressed with your care team, and a list is also provided in the NCCN patient guidelines. Continue to lean on your support team as needed. Their willingness to help you didn't just stop because your treatments are over. Try to find a balance between watching for reoccurrence symptoms and not allowing it to take over your life. This can be incredibly difficult and take some time to figure out the balance. And lastly, learn healthy habits such as eating right and being active. Even if it's just a short walk, every step can make a difference in your physical health, but also in your mental health. And with that, I will turn it over to Erin.
Okay, so we can now, we'll start the Q&A. Let's see, we have a question about the role of Herceptin for HER2 positive endometrial cancer.
Yeah, I can take that.
Great.
And thank you so much for that question. I was over my time by a minute or two, and so I'm happy to use this Q&A time as more time because this is very important thing that I did not include in my presentation. HER2 targeted therapies, so both Herceptin as well as trastuzumab deruxtecan, say that 10 times fast, are new agents that are really important for serous cancers that are HER2 mutated, or really any cancer that is HER2 mutated. And so this is definitely approved in the front line for serous cancer, and we give it with chemotherapy, also shown to have an overall survival benefit compared to chemotherapy alone. So a very important drug. It falls under that targeted therapies section that I didn't go into too much. So thanks very much for highlighting that, so we could get that info in. That's great.
We have a question regarding the hair growing drug minoxidil. Can you use it while chemo is still going?
I think it's better if you're receiving a taxane or an agent that causes complete hair loss to wait until you're done. All it will do is start hair growth and it will fall out each time. And minoxidil, you have to be compliant with it even after the treatment is done and you start on it. And that it works best if you use it daily. So I would say if you agents that take out your hair completely, to just wait until the end and then start on them. And there is a new oral medication for hair loss, but I have to Google the name. I apologize.
Great. Can you provide the suggested protocol for peripheral neuropathy supplements again? Is another question.
Oh, sure. It is magnesium glycinate, 500 milligrams a day, L-glutamine, 600 milligrams a day, vitamin B12, 1,000 micrograms daily, and I'm sorry, alpha lipoic acid is 600 milligrams a day. L-glutamine is 1 gram, 1 to 3 times a day. And there's 4 medications, and I think I mentioned them all now.
Great, thank you. Let's see. Okay, we have when you have a recurrence, do they restage your cancer?
That varies a little bit by cancer type. In GYN cancers, we tend not to restage. So we would just say like recurrent or metastatic stage, whatever the original stage was.
We have a question about, can you take Herceptin and another immunotherapy, and is in HER2 better than Herceptin?
Yeah, right now there are no approved like combinations of Herceptin plus immunotherapy that I'm aware of. So that's the first part. The second part was, is in HER2 better than Herceptin? That was the question? Yes. Okay. I think we don't know. They've not been studied, sort of head to head. I think they both play an important role. And HER2 is a drug that we've had super exciting data out in the last year. No sort of overall survival data yet, but definitely a drug with a really high response rate for actually ovarian, endometrial, and cervical cancers that are high expressors of HER2. So this is something we're all, following, but I don't know if we know which one's better.
Thanks. When one sentinel lymph node is cancerous, is there any way to tell how many other lymph nodes follow?
It's a great question. The studies that were done on sentinel lymph nodes suggest that if you have that patients that had one positive sentinel lymph node, around 40 to 50% of them had additional lymph nodes that are positive in the studies that did both a sentinel and a complete dissection.
This sounds perhaps like a question for Emily or Karen. Do you have any suggestions for addressing chemotherapy-induced brain fog?
I always tell patients to carry a little tablet around with them to write down their thoughts or questions, because it is a fleeting moment. and always doing those little Sudoku and puzzle games that I used to make fun of my mom for doing, but you know, the crossword puzzles, those make your mind think, and that's been known to help.
I would also recommend being active, taking a walk and keeping stimulated in that aspect. It really does help. And again, like Karen said, just taking notes and being patient with yourself and giving yourself grace it goes a long ways as well.
Let's see. So is serous cancer treated the same as sarcoma? Is another question that came in.
Generally treated differently, I would say.
Which occurs more frequently, uterine sarcoma or endometrial carcinosarcoma?
Good question. Probably pretty similar in overall incidence. One is sarcoma, which we said was really rare, and then the other is sort of a rare form of epithelial ovarian cancer or endometrial cancer.
Let's see. We have an inquiry about how are patient preferences incorporated into care decisions? Is that a part of the initial discussion of options or after recommendations are made?
Is that more directed towards how we communicate with each other as patients and providers?
I believe that's my impression.
Okay, I think I work with Dr. Barber. I'm very lucky, so I know she asks people their preference of communication, and I will do whatever the patient wants as long as I can take care of them and get them to the point they need to be. So we like my chart because you can attach things and because it's hard to remember conversations sometimes.
Thanks. Should you continue neuropathy meds after treatment?
You can, if you still have symptoms and they've worked.
One participant asked about the role of neoantigen mRNA therapies and their potential future role in serous and clear cell endometrial carcinoma in the future.
Yeah, I think that's something that is under study, but I don't, nothing that is approved or, kind of outside of trials for sure at this point.
Thanks, Dr. Barber. What can be done to deal with muscle and joint pain?
Being as active as possible. You can take some Tylenol or Motrin. Sometimes it's bad enough that we have to give you Tramadol or even Norco. But I would say being as active as you possibly can. Pilates patients report or yoga has helped many of our patients. Slowly stretching, thoughtful movements. Don't fly out of bed in the morning because sometimes you fall down. So take every movement slow and steady.
Someone asked about CDK 4/6 inhibitors.
Yeah, these were just added to the NCCN guidelines based on some phase 2 data that is out there now. I think that is it's probably not kind of front line, but I think that's a reasonable strategy. These are drugs that were originally improved in breast cancer, now sort of moving into other hormone receptor positive cancers.
How does Herceptin work differently than dostarlimab? Is one better than the other for mismatch repair deficient folks?
Yeah, so those are both kind of, targeted therapies. One is immunotherapy. So the dostarlimab, I think they said, not pembrolizumab, but those are both checkpoint inhibitors. Those are immunotherapy. For patients that are DMMR, so mismatch repair deficient, we would expect immunotherapy to work really well. Herceptin is HER2 targeted. So for patients that have HER2 mutation or, high HER2 expression on proteins, that's when I would sort of use Herceptin. But for someone who's DMMR, immunotherapy is really, really good drug.
In endometrial carcinosarcoma recurrence, should there be new, should histology testing and molecular testing be redone?
We don't really know, I think, is the answer to that. I think it would be reasonable to redo it, but it may not change like the molecular profile or like the NGS of the tumor. If it hasn't been done, definitely should be, but I don't know that necessarily needs to be redone.
Is there any indication that there will be increased research into uterine sarcomas?
Yeah, I know that they're on the national, there was actually a really big that when we mentioned the doxorubicin plus trabectedin followed by trabectedin maintenance compared to doxorubicin alone, that was a French study that came out actually this year. So that was not a regimen that was in NCCN or that we were given like, I don't know, a year or two ago. And now, that's starting to be something that's used. So I think that's a big advance. I think, all the trials in this space tend to be like sort of really large national trials, things like that, because it is a rare cancer.
How can I encourage my relative to be active when they are too tired or do not want to try? Also lymphedema. Yes, I guess just help with lymphedema.
So I think just being persistent, honestly, and it takes a lot. I got very comfortable being on the couch and feeling tired and not wanting to do anything. And it takes a little bit of encouragement and a lot of persistence to get you off and start doing it. But once you do, you will feel so much better. So just continue asking, maybe encourage other people and friends and family members to continue to ask the same thing. And eventually they're going to get tired of hearing it and just go. So just be consistent and persistent.
Lymphedema wise, we send our patients to lymphedema clinics if it's something that's persistent and not intermittent. Keep your legs when you're resting elevated. Sleep with maybe a pillow under your knees at night. Buy a good set of compression stockings that go above the knee. Often if they just go to the knee, they roll behind your knee. Lymphedema massage therapy often helps our patients, they report.
See, can a hysteroscopy allow the doctor to see a uterine sarcoma?
Not always. That's the tricky thing because it can be hidden in the wall. Sometimes, maybe half the time, but not always.
What type of cancer would one be susceptible to after treatment for endometrial cancer?
It depends a little bit. I mean, I guess, I don't know, maybe I'm reading too much into this question. I mean, so it depends a little bit on like why the person got the uterine cancer. I think you have to make sure there's not a genetic reason, right? And so if they have genetic reason, then there's all those Lynch syndrome cancers, kind of what we talked about. If they don't, then there are all the treatments we give do increase the risk somewhat of other cancers. So radiation, whole pelvic radiation can increase the risk of future cancers in the area that's radiated, like bladder cancer or, cancer in the colon, things like that. So they have like little different screening protocols. All the chemotherapies and those kind of things, it's very rare, but, and as are the radiation associated cancers, but they can increase the risk of like leukemias and things like that. So there's some treatment related cancers that people could be at risk for.
Let's see, a question about diagnostic testing. Does a PAP diagnose endometrial cancer?
It may not, unfortunately. It's the screening test for cervical cancer. We also heard maybe with Emily's story a little bit, like nothing is perfect, either. So that is a tricky thing about medicine in general, but Pap smear in general does not diagnose most endometrial cancer.
How often should you have a PET scan after chemo and radiation treatment for uterine carcinosarcoma? That's pretty individualized, or?
Yeah, I guess, I don't know, Kara, do you want to, I can answer it. I think we don't always use PET scan. PET scan is a very specific type of scan that we tend to use, like if a CT scan is sort of equivocal. Normally after treatment for like an aggressive or a high grade uterine cancer, some people might get some sort of imaging, and assuming that the patient is negative, like everything, the scan is clean, they might look like every 6 months for a couple years would be in the guidelines. But normally with like a regular CAT scan, doesn't have to be a PET scan. Maybe some cases a PET scan if there's some questionable finding.
We had a question about the best radiation treatment technique for this pathology. They cite IMRT or 3D CRT or VMAT.
Yeah, I think if it's external beam, I'm not a radiation oncologist, full disclosure. I do surgery and chemo, but not radiation. But I think, sort of extra EBRT, IMRT, those would be, people are trying to look at like sort of proton-based therapy. I don't know that there's any data that that's necessarily better, but I would say sort of EBRT or IMRT would be most commonly used.
Okay, this looks like this will be the last one. I'm surprised how few mutations have been identified as leading to individualized therapy. Is that expected to be expanded with future research?
Yeah, I think so. But I will say, I mean, I've been doing this like 15 years, Karen's been doing it longer than that. And I mean, we didn't have any targeted anything 10 years ago, so it may not seem like a lot now, but to me, it's a lot more than we used to have. And so I think that's the future, right? That's really where we're trying to go, is to really find these targets, find drugs that hit those targets specifically without other side effects. And I think especially with immunotherapy, Herceptin and, looks like in HER2, we are having really dramatic, outcomes for patients with these. So I think that's more and more where we're going, for sure.
Why isn't lymphedema or pelvic floor therapy typically covered by insurance?
Why isn't it?
Yes.
I guess I gotta be honest, there's so many different insurances. I really feel it's up to the individual insurance company, because they're the ones that unfortunately are making the calls. I've been lucky with our patients. I've not had anybody get denied for lymphedema therapy or pelvic floor physical therapy or for postmenopausal care in Chicago. So I think just make sure your provider fights for you. Like, I write letters all the time, and Dr. Barber makes fun of me.
I was just going to add to that as well. Just keep fighting. My insurance company is covering the pelvic floor physical therapy that I'm currently going through. But it did take some time. So just keep at it and keep asking, and have your doctors, your nurses, and other people express why you need to have this and why it's important in your recovery.
Great, so we are out of time for today. Thank you again to all of our presenters and everyone who joined. The NCCN Foundation would also like to thank our corporate supporter of this webinar, GSK.